All right, apologies. Yeah, so welcome everyone. This meeting will be going over, making the decision to use facet fuse. Will be co-hosted with myself, Vito Laurie. I'm the CTO at KIC Ventures, and Dr. Kingsley Chin. He's Harvard-trained orthopedic surgeon, is CEO of KIC Ventures and founder. So I'm going to turn this over to Dr. Chin and kind of kick us off. Let me get this presentation back up. All right, is everyone able to see that?
Yep.
Yeah.
All right.
Perfect.
All right, Dr. Chin, you want me to start by playing the video?
No, you just can. Thanks everyone for being on here. This is an exciting time to be in spine surgery. If you are able to see the future, I've been in spine surgery for decades, and now I think it's becoming more clear slowly that we have to change from the old way. And so this is going to be a series of these educational opportunities to talk about where are we going in spine surgery. And so this webinar is in that context. If you look at the upper right-hand corner, it says the LESS Society. And this society has been around since 2008, quietly. And the first four letters is a whole new philosophy that we invented back in 2007. When everyone was doing MISS, we thought there should be another way. So this technology, facet fixation, is one of those technologies that will usher in a new era in spine surgery. So I'm glad you're here and you're witnessing this and you can be a part of it. So let's start with the first slide. Vito, don't start the video yet, but I'm going to tell you a story about here in this video. I've been going around the country in the operating room, not doing the surgery, but just being there as a proctor and assisting. And this is a case that is becoming a familiar problem in spine surgery worldwide. And so I want you to listen to this story of this patient who had a successful lumbar spinal fusion with pedicle screws and interbody cages, but then found herself with a developing further problem above and had a prior laminectomy and 4 pedicle screws. And so I want to play the video for you to understand the story that is playing over and over in the world maybe not on LinkedIn, because everyone on LinkedIn want to show you their best stuff. But this is the story of the problem that we face. Go ahead. I can't hear the audio, Vito. Sorry about that. Yeah, Zoom had a problem with audio thing, so we're gonna get better at this.
Vito, I think Taylor put in the chat. You just when you hit share screen, there's a share audio setting. Might help.
Thank you. Oh, there it is. Apologies.
So I'm here in the office of interventional pain management doctors. I'm showing you this case, but there are like case after case of this same problem. Here's a full interbody fusion with pedicle screws. Now, what do you expect to happen over time? You see it here, where the level above is broken down, and this patient also has full laminectomy here. So full laminectomy, interbody fusion with pedicle screws. Now you need additional fusion. This is the revision epidemic that's happening, and as a result, you're seeing more and more need for interventional pain management doctors. This is the problem. And you see the breakdown of as expected.
All right, let's go into this presentation. Let's talk about this. What is the need? Traditional fusions are failing, right? And if I were to give this presentation at NAS or somewhere else, it'd be interesting, right? Because when you're changing things, there are three things that happen in sequence. The first is they criticize you. The second is they try to attack the messengers. And the third is when everyone accepts it, everyone claims to be the expert on it, even the people that were criticizing you. But traditional fusions are failing, and I'm starting to see orthopedic surgeons, neurosurgeons saying it for the first time. Here's a paper that was published in our top orthopedic journal, Journal of Bone and Joint Surgery. And it looked at facet arthroplasty versus fusion, pedicle screws. Now, I don't want you to focus on the facet arthroplasty. I want you to focus on the fusion arm. 11.4% of the patient in the fusion arm develop a new or progressive neurological deficit. But almost 45% of the fusions failed within 2 years. What do you think it's going to be by 5 years, 10 years? This is failure, right? This won't play well on LinkedIn. here's a case of what really happens every time. Right? Look at the progression from 2 years to 13 years. And, you know, Matt Lazary has been very vocal, and they talk about sagittal balance. If you look at pedicle screws, you see a problem with sagittal balance. These patients end up with flat back. A lot of times they're fused in flexion. Next. One of the problems, especially with young surgeons who claim to be MISS, right? They go to SMIS, is they're using fluoroscopy and they're putting pedicle screws in. And the bullseye is the pedicle. But what is above the pedicle? The facets. So when they study facet joint violation, and these are normal facets, not the disease facets, 27% of the time in this study, they're violating the facets. And there are two types of violation. One is your pedicle screw is next to the facet. So every time you move, some patients have a clicking sound, they can hear it, or you keep rubbing against the pedicle screw until you break down. And then there's another group of patients who the surgeon placed the screw straight through the facet. It looked like bullseye, right, on fluoro, but you're going through the facet to get to that pedicle. And those patients will break down. Next. So what is it? What are we trying to do in the spine industry to help keep pedicle screws and cages going? Well, if you want to think about the car industry, keep making bigger engines, right? Maybe you make the fuel more efficient, but it's still a combustible engine. So we're introducing robots. How many countries are you going to bring robots in to help spine surgeons put pedicle screws in? And most of these surgeons who fly from overseas, they come to a meeting and watch someone talk about pedicle screws, and then they go back and maybe look in a magazine or a technique and try. A robot is going to cost you over $1 million. And a lot of setup time and a lot of fiddling around just to put a couple pedicle screws in. Next. So let's talk about what you need to treat. The most obvious is spondylolisthesis. And that's when there's a slippage, there's degeneration. This starts with the facets breaking down. And if you look on the right on the axial, you're going to notice those facets are pretty bad and they're fairly vertical. So you start to slip. Next. Facet tropism. Most 99% of spine surgeons, 0% of interventional pain management doctor will know about facet tropism unless we teach them about it. But Scott Bowden, when he was at UPenn, studied facet tropism, right? And if you look at the Tower of Pisa in Italy, where it's tilting over, facet tropism says your facets on both sides should be the same design by nature. Tropism occurs when they're not. And if they're not balanced, you end up with degeneration of those facets. And over time, those patients are going to end up with a spondylolisthesis. This is why we're pushing for earlier treatment. If you see facet tropism and you decide what you want to do is keep doing injection dispersion, RFA, all you're doing is pushing the disease process inevitably to spondylolisthesis. So you want to fix these patients earlier. Next. Facet joint fluid. You know, you see the patients come with back pain. They're sitting, as they're getting up, you know, they have a little discomfort. As they walk around, they feel better. You know, so you think that's nothing. But, you know, it's like fluid in your knee and your hip. There's a problem. And we want to see these patients treated earlier. You can get them better with injections and medial branch blocks and RFA. But again, we want you to treat these patients earlier. And if you want to follow interventional cardiology, you have a choice. You can treat a patient beta blocker and wait for them to show up in the ER at 4 a.m. with frank heart attack, or you can treat them early enough when you can actually go in there and put a stent. So I want us to understand we're trying to get to these problems earlier. Next. So this is a common finding. Patient has severe ridiculous symptom sciatica because there's a facet synovial cyst that's filled with fluid and it presses on the nerve, right? Now you can go into the needle and drain it, but it's not going to go away. This only goes away if you actually resect it or if you fuse the joint. So most spine surgeons are trained to go in and resect it, fuse the joint, because if you resect it and there's still motion there, it's going to form another cyst. Mm-hmm. So you want to stabilize the joint when you see this. Yeah. So far, I've just touched on a few indications. Towards the end, I'm going to come back to a few cases. I'll turn it over to Vito.
All right, everyone. So as we talked about the problem and the need, now we're getting to the answer and how that fuse fits in here. So Dr. Chin talked about from pedicle screws, see the larger construct, we get down to the facet screw with smaller incision. We further simplify as we get to interspinous fixation, where we're decompressing and fixating with one device. As we talk about simplifying for outpatient spine fusion, we noted the step fuse implants are indicated for trauma, spondylolisthesis, pseudoarthrosis, degenerative disc, and facet disease. And you can see here, that small midline incision that both implants going in on. And when you compare that to coming from pedicle screw with those bilateral implants coming out from more lateral than medial with larger incision size to get 4 screws in, you can compare and see the small incision size. So our facet fuse will compress the joint. We have lag screw that the lag where there's no thread is across the joint. So as you seat the screw fully down, it compresses the joint to promote fusion. We decorticate and add bone graft to that area, and we get great results on the fusion side. A little bit more background of our technology. We have FDA approval since 2008, so a lot of history in the operating room with our device. There's 4 main different styles. We have this kind of pink screw is showing the typical lag screw that where the joint is across where there's no threads and we get compression. We have a fully threaded, which could allow you to hold a decompression state or position, and different styles of washer. There's a small washer, a large washer, and then we have a washerless when the anatomy is very tight, and we're still able to get our fixation in. There's comprehensive sizes. We go from 25 to 50 millimeter in length and 4.5 to 6 millimeter in diameter. Interesting thing about the diameter is as we grow in diameter, we're growing our thread profile. So the the minor diameter stays the same. So the inside of the screw stays the same, and the thread keeps getting bigger, which allows us to exponentially increase our fixation as we go from 0.5 millimeter diameter increases. So that's very significant. The patented polyaxial washer contours to the facets. It's a very organic anatomy there. So the fact that it moves around will capture and distribute the load. We have a double row of opposing teeth. So we get a good grip, and it really keeps the head of the screw and the screw in place as the joint wants to move. And of course we have the cannulated screw, being able to implant this over a guide wire percutaneously. And then we have key patents around the device, and that's really been the bedrock of starting the system and designing. That's the technology. I'll hand it back over to Dr. Chin, kind of keep going around over the proof.
Yeah, so thank you, Vito. So one of the areas that in the social media that we get a lot of arguments on is, you know, doctors who were never trained on this, never been exposed on it, but they're trying to think intuitively, how is it possible that, you know, something other than pedicle screws can actually work in spine surgery? And so you need proof of that. And as we provide the proof, I think you're going to see, you know, wise people start to pay attention. Facet fixation has been around since 1945 by Dr. King, Dr. Bouchard, and Boucher and Dr. Margaret. Plenty of data on it, but let's talk about facet fused data. This is a study that was published last year in the Journal of Spine Surgery. This was done by Neil Crawford. Chris Benton and I know Neil Crawford is at Barrow Neurologic Institute, PhD. He's no longer there because he actually developed the Excelsior robot for Globus. So Neil is a very smart guy, right? So he did the study where he looked at facet fused versus 2 facet fused versus 4 pedicle screws. And the data is pretty conclusive. This is a top peer-reviewed spine journal by orthopedic surgeons and neurosurgeons. So this is not a throwaway journal. This is not a pain journal. This is not a what do you call it? Just an online journal. This is a fully, rigorously reviewed article. And it showed that 2 facet fuse the immediate stability is greater than pedicle screws. I got to be careful in how you interpret this. Doesn't mean that it's clinically relevant, just so we be clear here. But just from a biomechanical standpoint, when you compress 2 joints together, it is, even at the micro level and even the macro level, is more stable than 2 pedicle screws in a rod. If you were to do that surgery, you may not see a clinical difference in terms of stability, right? Because 2 pedicle screws are very strong. It just shows you that 2 facet fuse are very strong as well. Next. Plenty of papers you can review, and this is going to grow as when doctors take a long time to change, and they do that quietly. What's going to happen is more and more doctors are going to quietly use facet screws and quietly publish on it before the meetings are always way behind, and academia are always way behind. So facet fixation has been around for a long time, but the industry was too strong for pedicle screws. Now that we're out here pushing this, I think you're going to see a lot of changes. And some of these papers are not even ours. So more and more papers are starting to quietly come out proving facet fixation. Next. I want to make sure we differentiate between transfacet pedicle screws and putting a wedge in the joint. So we're talking about pedicle screws. You're just going medial to lateral. Next. There's not a lot of proof for putting a wedge in the joint. Just so you know, there's no difference between pedicle screw, coding and reimbursement, and facet fuse. It's a pedicle screw. It's just a transfacet pedicle screw. Next. So 22612, 22840, those are the two codes. And if you do a decompression, 63047. Next. The technique, you're basically going medial to lateral, you're going across the facet. And usually you can see the facet on the oblique views, and you're trying to start medial to it and go across into the pedicle. And if you've done a kyphoplasty, which is harder, you're basically going the opposite of a kyphoplasty. Kyphoplasty goes lateral to medial, facet fuse goes medial to lateral. Next. All right, let's go through some cases. So a classic case is a grade 1, grade 2 spondy, right? You don't need to mess around with the disc. Just do a decompression and fixate the facets and put bone graft over there. And we can train you on those techniques as well. Next, that's your classic case, especially at 4-5. And here is an example, right? You see this case patient at grade 1 spondy, mild, some degeneration of the disc. Disc height is about half the size height of the other ones above. In this case, this was my case. I actually put bone graft in the joint, in the disc. I took the disc out and placed facet screws. If I were to do this today, I wouldn't mess with the disc. You know, that was, you know, when I wasn't fully transitioned yet. And I thought I'd bought into the idea industry about, hey, in order for you to have fusion, you got to take out a disc and put something in there. Today, with our rep philosophy, we don't believe in that. We want to restore function, early treatment, and preserve anatomy. We don't want to get rid of an anatomy here. So this worked, but I wouldn't have touched the disc today. Next. Now, this is a case by Doug Beal. I don't know if Doug's on here, but he called me up. He had done a Minuteman, and it didn't heal. And I think he had taken a long hours to take out a previous Minuteman, and I don't think he wanted to do it again. So we gave him the facet fuse to just fixate the patient. We thought there was enough foraminal room, but you need to stabilize. And he noticed he used no washer here because it would have been difficult to get around the implant that was there. So if you want to treat a failed interspinous device, you don't want to take it out, you probably can just put facet fuse and stabilize the joint. Next one, Vito. You know, for a lot of, so we've done about 13,000 of these, and we have a lot of spine surgeons who actually use us. They're just quiet. But for a lot of them, they will do one side as a T-lift, take out the facets and put pedicle screw there. And while they're over that side, just fire facet fuse on the other side. And if the disc is high, you know, you in order for you to fuse the disc space, you need strong fixation. So they do pedicle screws on one side, where they take the facets out and facet fuse on the other. So you can do a hybrid. Next. You know, this is, you do a lateral cage or P-lifts, the facets are still in place, and you just fuse the facets, and this will compress the segment together, give you more lordosis. Whenever you use facet fuse, you're getting more lordosis because you're compressing the facets together. Next. This is a patient I did very heavy, large patient, and a fuse of facets for her, and she's done extremely well, man. She's over 10 years, and the facets are completely fused. I'm happy for her because she, we preserved the disc mostly. Next. This is what the story that I started out with, where in the old days, I would have to go and make a big incision, right? Take this rod out, put, go all the way up, put pedicle screws above, put a longer rod in, or I would have to put pedicle screws in and domino, connect a short rod to this in the back. And maybe I would do a lateral cage on the side, a big surgery. Today, I've had a lot of my friends in the pain management world just go in and do a decompression and put 2 facet fuse around. And you got to learn how to do this. This actually takes some artistry, because you have to try and get around the pedicle screws there, or sometimes you have to just go short enough to just get to it. So you're going to use your obliques to kind of figure it out. But I can support you on that. I can train you on that. But this is a great solution. Next. This is a case where great fusion here with interbody cages and the facet fuse. This is a solid case. I can't argue with this if someone feels. If you do an interbody cage, especially an ALIF or lateral, facet fuse should be the most you put in. Pedicle screws just should not even be used here. Right? So this is a great indication for anyone who loves ALIFs and lateral cages. Next. Here's a case. I'm seeing more and more of these, cases, because you do it, especially for pain management, you want to keep the space open up. So you put an in-span in, and you feel like, I need a little bit more fixation. You just do 1 screw. And I saw Dr. Yadu just posted one of those on LinkedIn. This was my case here, and it's just a great solution. Next. And sometimes, you do bilateral. I think this was my case as well, where I needed a little bit more fixation at 5-1. And so I put an in-span in. This is an in-span Vega. It looks like a Mickey Mouse head, and 2 facet fuse, right? These patients do really well, and I'm avoiding pedicle screws, which is fantastic. Classic case of spondy at 4-5-1 at 5-1. And I think this costs, again, you do facet fuse at 5-1, and then an in-span at 4-5. So you're combining with an in-span, but not at the same level, right? So more and more ortho, especially, are doing a 2-level, where the lower level, they use facet fuse and do a soft stabilization at the level above with in-span. Next. This is getting more excitement, but I'm still waiting for pain management to start doing these. But, this is a case of mine where, especially a lot of young patients, you see a pars fracture, get a CT scan, get to see the morphology of it. If flexion extension, if it's moving, you really have to compress it together, and you basically put a facet fuse across it. You're going up and across the pars, and you probably could also put an in-span in to back you up. But facet fuse, we have a long history of using it for pars fracture repairs. Next. So, in order for us to challenge traditional spine surgery, we really have to invest in training. And so we welcome anyone on here who hasn't been trained to come to Florida, Fort Lauderdale, and you get trained. You're going to get trained on a new philosophy of spine surgery. It's less exposure spine surgery. Next. So, you get a certificate, you get proctoring from us. And as you do more cases, we want you to publish papers with us. And eventually we'll give you a fellowship certificate from the Less Society that you're fellowship trained by orthopedic surgeon and neurosurgeons and interventional pain management colleagues. We have more and more papers coming out now to show that interventional pain doctors can do sacrex and in-span and facet fuse if they're trained properly by a spine surgeon. So in this picture, I'm there for the training. On the right is Dr. Mazia. He's a orthopedic spine surgeon as well. So we have everybody using Nanisc right now. It's not just one specialty. Everyone is. Thank you for your time.
All right, thank you very much, Dr. Chin. We can open it up to see if anyone has questions on the presentation.
Screw selection. How large do you want the screw? How far do you want it to go? What's the ideal?
Yeah, so it's a great point. I tried to, so you have a 4.5 by 25 millimeter. That's your shortest screw. You shouldn't use a 4.5. We started out there, and I think a lot of other surgeons have had failures with small screws. And so now we're up to a 6.0. And so if you're at 5.1, I usually recommend a 6.0. If you're an interventional pain doctor, I think a 30 or 35 millimeter should be where you are. 35 millimeter is phenomenal. Orthopedics guys can sometimes be more aggressive, go up to a 45 millimeter, 50 millimeter screw. In order to do the longer screws, you have to decrease your lateral trajectory because you would come out the side. So when you go in with our jam sheet and needle, you're able to measure where you are, right? And you can tell from the jam sheet where 50 millimeter is at. And you can also, when you're tapping, you can read off from the cannula how deep you're tapping. And so you can always vary your screw length. But if you're going to do a 5.1, I would say a 6.0 by 35 screw. If you're going to do a 4.45, if you have a lot of motion at the segment, I would use a 6.0 again by 35. If it's rock solid bone, younger patient, the disc is very degenerate, fairly stable, a 5.5 screw is good enough. As you go higher up the spine, into L1, L2, you probably want to use 5.0s just because the spine narrows and you don't have a lot of medial lateral room. So your workhorse should be 6.0, 35 or 5.5, 35.
Thank you. Also, I think, Dr. Chin, we were in a case one time where we had very difficulty seeing the images on fluoro. What are some of the workarounds when you have that problem?
Yeah. So, if you're ortho and you have an open wound, you can actually see it. And, you can always sound the pedicle and tell if you're in or not. But the oblique is usually, a great way to really look at that pedicle. And usually you can see usually on your AP, you're good. Your lateral can be tough, heavy set patients. But, you got to tilt to square off your end plate, really get a chance to see things. And on your lateral, you're really trying to picture that foramen and the end plate, making sure that your anatomy is not being violated. So we'll train you on all that when you come here. You should be able to make it out. But if you have someone that's very old, and you really have to look hard and try to make sure that you're in the pedicle. And if you're aiming laterally, you're not worried about any nerve injury, but you really have to make sure that you know where your foramen is located, so you're not going through the foramen.
Got it. Thank you.
Jin, what's your thoughts on after you implanted the screw about doing the supporting patient after they maybe?
Yeah, you're cutting out, but it's very, I've had to learn this lesson because, when you do the surgery, it's so, it's a tiny incision, right? You're not violating any anatomy, right? You're going in with a tube, you're putting the screw in. These patients really don't hurt that much after about a week. So they, unlike pedicle screws, they're going to want to do a lot of stuff. So, you really have to slow them down. But, I give them a brace and try to tell them to take it easy. This is just not a painful surgery, and they'll want to do a lot. So you just got to tell them to slow it down and just kind of, it takes about 6 to 9 weeks to heal. A lot of that has to do with how much bone grafts you put around it, how much you decorticated facets. You want to really prepare those facets and put nanofuse on. All right. Any feedback on this presentation? Was it good? For any particular reason or anything else you'd like to see? This is just the start. This is the beginning. We're going to do a lot of these.
Well, I enjoyed it. It gives a lot of transparency with what we're doing. The imaging is great. I love that. Showing exactly what we're looking for. Just a question on the measuring, because this is kind of what my understanding has been thus far. Within pain management, we basically just want to breach the posterior wall of the vertebral body in the lateral with the screw, right? Is that about the length that we're trying to go for? I know spine guys are going a lot deeper, but within pain management, I've been saying basically, in the superior aspect of the pedicle, just get past the posterior wall of the vertebral body, and then we measure from there.
Yeah, that's a great measurement, and it's similar to kyphoplasty. Yeah, you must pass the posterior wall, and if you look on your oblique and you still have lateral vertebral body still there, you can keep going for a little bit more, because, you know, the longer the screw, the better, stronger the fixation. So
Okay.
usually if you just get to the back of the vertebral body, you're about a 30. So anything beyond that, you're getting to your 35 to 40. I don't expect you to put anything longer than a 40. A 35 is kind of a really nice screw.
Okay. Thanks.
Great point. We probably should show that in the next one, show the posterior border, how we're trying to do it. You know, we didn't show you everything, how to do all this, right? Because you have a lab. You come here, you're gonna learn all that.
Dr. Kingsley, can we discuss a little bit about NSAIDs restrictions pre and post-op?
Yeah, you know, you're doing a spinal fusion, 22612, you shouldn't be smoking or being around a smoker, and you shouldn't be taking anti-inflammatories because those can impede the fusion, right? Fusion is an inflammatory process. So, you know, for pain medicines, I look at things like tramadol, or if you want to do some narcotics. These aren't very painful. So, you know, about a week, you should be good to go. Tylenol with codeine or something like that. And by the way,
Thank you.
these can be done on the local, right? Or I just did a bilateral with sacrix in Jamaica. Patient wanted a spinal. The anesthesiologist wanted. She does a lot of deliveries, and she's very good at spinal. That spinal worked really well. But I know Dr. Panazzo and some other guys, you know, you're wide awake and they're doing a lot of local anesthesia. So, you know, this is truly less exposure surgery. You know, it's truly a change in how you can do surgery with a 1.5 centimeter incision in the midline. You know, it's just the moment you start doing this surgery, you go through a transformation. And I know for Brian and the guys in Phoenix, Dr. Panazzo loves this. Dr. Deitch with Matt Lazary loves this stuff. You know, so Dr. Cesar and Dr. Costigan, and more, once you start doing this, it's hard to go back, right? It's like if you own a Tesla, you're charging at home. Going to a gas station, unless you want to go buy some cigarettes, doesn't make any sense anymore. What else do you buy at a gas station? Like a banana, ripe banana for 25 cents? All right. I want to shout out to all the doctors who are on here and all our team that's trying to change the world. We're going to have more of these so we can educate people and more training labs, each one of the doctors who become an expert. I hope you guys would give back and train other people. This is the future, you know, and it's crazy to see all these pedicle screw cases being shown in the public. You know, there's no way patients are excited to see those things. So, all right. And I think I'm good here.
Dr.
Thank you,
Chin,
guys.
Vito, thank you so much.
Appreciate all
Thank
you
you,
guys.
Dr. Chin.
Thank you, guys.
Thanks, everyone.
Later.